This is the endovascular embolization of a very distal posterior cerebral artery rupture arteriovenous malformation. We present in the intermediate catheter support technique. The patient is a 35-year-old female who presented with a ruptured arteriovenous malformation during pregnancy. Patient recovered from the hemorrhage, and after delivery, a cerebral angiogram was performed demonstrating a small arteriovenous malformation that was fed mostly from the left posterior cerebral artery. This MRI and MRA demonstrate the intraparenchymal hemorrhage and the small arteriovenous malformation. After a conversation with the patient and the family, the risk, alternatives, and benefits of different approaches were offered, and the family and patient decided to go for endovascular embolization. Under conscious sedation and through a right femoral artery approach, access into the left vertebral artery was obtained. Using a triaxial system that consists of a 6 French guide catheter, a DAC or distal access catheter, and a microcatheter microwire, the left posterior cerebral artery is approached. Here you can observe the microwire microcatheter had made the first turn. The more distal and the more tortuous, the more difficult to navigate microwire microcatheter it is. Here you can observe the microwire is trying to find the larger pedicle into the arterious malformation. As we push the microcatheter over the microwire, observe what happens to the microcatheter. There is significant pushback and the microcatheter is not able to advance. More proximal support is needed, therefore we advance the distal access catheter more distal into the proximal or even mid portion of the posterior cerebral artery. The microwire is removed and a microinjection of the PCA is performed, observing that the catheter is not distal enough into the arteriovenous malformation. Therefore, we need to reaccommodate the wire and the microcatheter more distal into the AVM. Another injection through the microcatheter confirms the excellent position of the microcatheter, and we are ready for embolization. After priming the microcatheter with DMSO, we then slowly injected onyx. In this case, we use onyx 18, and the injection is in a steady, pulsatile, continuous manner, observing the onyx penetrating into the arteriovenous malformation. It is important to keep the eye on the catheter to identify early reflux. We tolerate minimal amount of reflux because the catheter might get stuck and it will be very difficult or even harmful to pull the catheter, especially in this distal territory of the vasculature. At this point, there has been minimal to no reflux, and all the onyx is going into the arteriovenous malformation. We now pull the microcatheter back slightly, and from this new position we further inject onyx. Observe that there is already some amount of reflux and we decide to stop. Controlled cerebral angiography demonstrates complete obliteration of the arteriovenous malformation. And now we proceed with removing the intermediate and the microcatheter. The distal access catheter is advanced as far as possible into the posterior cerebral artery and as close as possible to the microcatheter tip. Having this distal access catheter gives support to the microcatheter be able to remove. Observe how the arterial pedicle is being pulled while we pull the microcatheter, and then it finally releases. Having this intermediate catheter reduces the amount of force necessary to remove the microcatheter and prevent rupture of the vessel. Post-embolization angiogram demonstrates complete obliteration of the arteriovenous malformation and no contrast extravasation. The patient recovered very well from the procedure and stayed in the hospital one day and discharged home the following day. Thank you.